Are we starting? Are we starting? Hi, good morning, everybody. These are some trivia questions we're going to start off with. Thank you, everybody, for participating.
So, good morning. We started off with just a brief little trivia. Welcome to the first session, Multimodality Therapy for Locally Advanced Renal Cell Carcinoma. I'm Deborah Kay, and I'll let Dr. Berg introduce herself.
Hi, good morning. I'm Stephanie Berg. I'm one of the junior faculty leads of genitourinary oncology at Loyola University Chicago. Thank you again for the committee for allowing us to moderate this session today.
So I'd like to first welcome our first set of panelists for a discussion of multimodality therapy for locally advanced renal cell carcinoma. First is Dr. Elizabeth Wolfe-Birchfield. She's assistant professor of medical oncology and palliative medicine at the University of Kansas Health System in Kansas City, where her area of specialization are in medical oncology and outpatient palliative medicine for patients with cancer. And then Dr. Pedrosa is a tenured professor of radiology and urology at the Advanced Imaging Research Center in Biomedical Engineering at the University of Texas Southwestern Medical Center. And then Dr. Sheth is an assistant professor in the Department of Interventional Radiology at the University of Texas MD Anderson Cancer Center in Houston, Texas. And we're really delighted that all of you could join us here today for this presentation.
So I'm going to start off, as Dr. Campbell did in our previous lecture. We always like to start off with a case. This is a patient of mine. It's a 64-year-old male. He presented with shortness of breath. He was found to have a left lower lobe PE, a 5mm right lower lobe nodule, and a right renal mass as pictured. He has a past medical history of hypertension, reflux, diabetes, OSA, and TJD. So we're just going to do a quick poll to the audience. What would be your next decision in management? Again, this is our multimodality therapy here. Would we choose to go to a cytoreductive nephrectomy? Sorry, I think I sent a survey again. Sorry. Cytoreductive nephrectomy, systemic therapy, then cytoreductive nephrectomy, or perioperative clinical trial. I think I might have clicked it too fast.
So we'll come back to the case later, but we'd like to start with Dr. Wolfe-Birchfield, who's going to discuss palliating unresectable kidney mass via systemic therapy.
Good morning. Well, we know that we'll have a really rousing discussion about all sorts of modalities for treating patients who have locally advanced kidney cancer. But first, I just wanted to share a little bit of a medical oncology and palliative care perspective about how to manage some of these systemic approaches. And what I would say is that when thinking about an unresectable kidney mass, I think it's really essential for us to know whether that's unresectable for anatomical reasons, which I think that's what most of us would think about, but or whether the person cannot undergo surgery because they are too medically frail. As we have all seen, these can be very different situations that need their own approaches. also, I think it's really important to discuss and achieve alignment on what palliation means for each individual patient. Do we mean simply relief of suffering, or do we mean that the person will have extension of life and cancer control without the expectation of cure? While I think palliation can be used literally, and that was the focus of my talk, which I certainly encourage you to watch as supplemental material, a lot of times in oncology, our perspective is that palliative therapies really are treatments without curative intent. When thinking about palliation more in the literal sense, and some in the sense of just trying to promote longer life expectancy and disease control, when thinking about systemic therapies for this purpose, my take on things is that I think it would be of value to use the treatments, systemic treatments with the highest overall response rates. And while we certainly have seen some really high impact work done previously showing that tyrosine kinase inhibitors can do this, more recent regimens using tyrosine kinase inhibitor and immune checkpoint inhibitor combinations have even higher overall response rates. And while it is difficult for us to know exactly how the relationship of overall response in systemic metastatic disease relates to primary kidney masses, there is data demonstrating that these TKI-IO combinations can have good responses in the primary tumor. Another thought I wanted to mention was simply that patients who need palliation initially, but then may be eligible for a consolidative nephrectomy in the future, that prolonged courses of immune checkpoint inhibitor therapy may lead to increased desmoplastic reaction that could make it more difficult surgically. And while I think we have wonderful upcoming trials that we should all support in order to try and answer those questions, finally, the palliative care physician and me could not get by without mentioning a few palliative care pearls in these situations. Generally, I would say, in the situation in which a patient is too sick to undergo definitive surgical management, it's really important for us to all be using our best primary palliative care skills. Some tools that we often use in specialty palliative care that you can apply to your practice is shared decision-making and discussions surrounding best case, worst case scenario, which is wonderful work done by Dr. Schwarz. Use of statements like, I'm worried, in order to cultivate their prognostic awareness. It can be extremely helpful and communicate more than even what those two little words can say. And then trying to do some advanced care planning whenever possible. As always, consider bringing in your friendly neighborhood palliative care physician in order to help support you, your patients, and their loved ones.
Thank you so much. So a little bit more about the case, just to kind of bring it back. So this patient did have the CT. He showed an 11.5 centimeter right lower pole renal mass. It did have tumor thrombus extending into the IVC. And then he also had multiple enlarged lymph nodes. So per the polling, he did actually undergo a right thoracoabdominal nephrectomy. So what would be everyone's next decision in management here?
So next, while we're answering that, we're going to go to Dr. Pedrosa, who's going to speak about imaging for locally advanced renal cell carcinoma.
Hello, everyone. Thank you very much for the opportunity to be here today. This is a summary of the material that is available online. And in terms of staging advanced disease, as the case that we are presented here today, the three ways we're going to see advanced disease locally is by direct infiltration of the perirenal fat by the mass, by extension into the regional lymph nodes, and then intravascular tumor extension into the renal vein, and then into the IVC. The last two have substantial implications for management in terms of surgical planning. Unfortunately, the detection of lymph node metastases is still very challenging for us. Micrometastases are below the typical spatial resolution of the techniques that we have today to image tumors in vivo. So small metastases in a normal, otherwise normal-looking lymph node are frequently missed on imaging. Similarly, lymph nodes can increase in size. They can be enlarged, as is the case in this particular patient, and not necessarily have involvement by tumor. It is known that probably between 50 and 60% of the tumors that are enlarged are so because of the reactive hyperplasia that occurs in the setting of inflammation, and not necessarily because of metastasis in the lymph nodes. So it is a reason for false positives. So again, in terms of staging primary tumors, the absence of enlarged lymph nodes doesn't mean that we don't have micrometastases, and the presence of enlarged lymph nodes doesn't mean that those are necessarily involved by tumors. So we don't have currently a great approach to stage regional lymph nodes. There are some promising techniques, particularly with molecular imaging, but those are still research tools and not widely available. In terms of the extension of the tumor into the venous system, into the renal vein and IVC, that's a different story. We actually have very good techniques to image those characteristics of the tumor and really help the urologist plan the surgery, or in the cases when it's chosen to do systemic therapy to assess response to treatment. It is key for us to delineate the extent of the thrombus because the surgical approach varies dramatically. So we typically use the level of the renal vein, the level of the hepatic veins, and the diaphragm as the key anatomic landmarks to define the extension of the tumor. With a multiphasic CT, that means we give a IV contrast dye, and we do multiple phases of contrast with a CT. That's very adequate for imaging IVC thrombus, but sometimes an MRI can be helpful in some of these cases where there are more challenging delineation of the tumor thrombus. There is some current literature on assessing the likelihood of wall invasion in the venous system, and in that sense, one can provide some quantitative measurements of the thickness of the thrombus in the IVC to try to predict if the patient is going to need reconstructive surgery during the removal of the tumor as well as the tumor thrombus. So those are starting to become a little more used more frequently. And finally, we have to look for complications of venous thrombus, specifically Budd-Chiari syndrome, which is the obstruction of the hepatic venous outflow because of the thrombus extending at the level or above the hepatic veins. And there are some signs on imaging that really suggest that, and sometimes that's really clinically not suspected. And it's important to inform of that because there is actually increased perioperative morbidity and mortality. So we look for free fluid in the abdomen, ascites, as a sign of hepatic failure. We look for abnormal enhancement of the liver parenchyma as well as a sign of venous congestion. Thank you very much.
Thank you, Dr. Pedroza. Just to go back to our case a little bit, because we're going to wrap it up in a minute. So this patient, he still had some disease left in his left hilum. He did receive SBRT to this leftover disease. Just to remind everybody that this was not biopsy proven as kidney cancer. And then unfortunately, he did relapse from his high-risk disease. But before we ask our questions, we're going to go to our last presenter, Dr. Sheth, to talk about some image-based local therapy for oligometastatic disease. Dr. Sheth.
Great, thanks a lot, and thanks for the invitation. This is really a pleasure for me to be a part of this. So like the moderator said, I'm an interventional radiologist at MD Anderson, and interventional radiology intersects a lot with patients with kidney cancer, mostly in the early stage setting. So for T1A, we do a lot of thermal ablation for local control of the primary tumor. And of course, we do biopsies for patients who have metastatic disease. But the goal of my presentation that's online is to sort of highlight all the other options that we can provide for patients, both in the oligometastatic disease for local control outside of the kidney, as well as in the palliative setting for patients with more widespread disease. So as I'm sure the audience knows, renal cancer can go pretty much anywhere. The most common sites, though, are lung, bone, lymph node, and liver. The good news is we have treatment options that are relevant across all of these different anatomic sites. And so one of the take-home points in my presentation is to sort of make sure that everyone is aware that these sites can be treated, again, with the goal of local control as well as palliation. And in particular, we're using techniques that are generally a combination of different modalities that are aimed to kill the tumor. Just acknowledging the fact that renal cell is well established as a radioresistant tumor, but it's also resistant to other modalities such as thermal ablation and transarterial embolization. So we really try to belt and suspenders it when we come to taking care of these lesions. You'll see some case examples in the presentation about each one of these tumor sites and how we can be aggressive about taking care of those lesions with these combination modalities. And the other take-home point I want to emphasize as well is the palliative nature of this. Renal cancer loves going to the bone, and particularly the pelvic bones and weight-bearing bones. These sites can not just be harbors for disease that are resistant to systemic therapies, they can also be very symptomatic for patients. And so our goal there isn't to just kill the tumor, but also to stabilize the weakened bone with various forms of augmentation, including cement or percutaneous screws. And these can all be done in a minimally invasive manner for patients who can then be discharged within 23 hours. So these are all potential options for patients who have oligometastatic or more widespread disease. And so it's worth considering a consultation with your local neighborhood interventional radiologist to see what options they can offer your patients. Thanks.
Thank you. That was great. We had a lot of questions we wanted to ask the presenters, but it looks like we're running short on time. So we are going to go to Dr. Hawes, who's going to present on target populations for adjuvant and perioperative trials. Dr. Hawes is a professor of medicine at the Abramson Cancer Center in Philadelphia. She has developed and led multiple investigator-initiated industry and cooperative group-sponsored trials in GE malignancies. And we're delighted to have her speak with us today. Dr. Hawes?
I'd like to thank the organizers for inviting me to speak, and here are my disclosures. I'm going to cover a couple of objectives in this presentation. One of them is to briefly go over the ongoing perioperative trials, but also focus on what we know about patient and disease characteristics and how we might apply these to future trials. So most of you have seen these slides before, but this is a depiction of the Kaplan-Meier curves of the adjuvant trials using the VEGF receptor tyrosine kinases, which were completed several years ago. The only one that has not reported out is not a VEGF receptor tyrosine kinase, but it's the everRECIST trial, which is shown at the bottom of the slide here. And importantly, really just the S-TRAC trial showed an improvement in disease-free survival, and this was in the very high-risk PT3 clear cell population. So, and none of these trials have gone on to show an improvement in overall survival. Hence, the enthusiasm and need to go forward in looking at some of the immune checkpoint inhibitors and their possible role in adjuvant therapy. So this slide shows the phase 3 adjuvant and perioperative immune checkpoint inhibitor trials. PROSPER is a cooperative group trial which gives one dose of nivolumab prior to resection of the primary, and the control arm is surgical standard of care without a placebo arm. The EMOTION and the Keynote 564 trials have completed accrual, and these are also, all three of these trials include allowing metastatectomy, so a somewhat higher risk population. The Checkmate 914 trial is still open in accrual and has recently expanded to 1,600 patients, adding a single agent nivolumab arm. And the Rampart trial, which is open mainly in Europe, looks at adjuvant durvalumab and tremelimumab, also in a similar setting versus standard of care observation. These trials answer some important different questions. The PROSPER trial is asking if neoadjuvant priming using these intact kidney cancer cells are safe, and does it lead to better outcomes versus a observation or resection control arm. The EMOTION trial is asking whether PD-L1 therapy is better than placebo. And 564 is asking if PD-1 therapy is better than placebo in the adjuvant setting. The CheckMate 914 setting asks if dual immune checkpoint inhibitor therapy is better than monotherapy or placebo. And the RAMPART trial asks if dual immune checkpoint inhibition is better than monotherapy or standard of care surgery. What I'd like to do is switch gears now and discuss a meeting that was held in November of 2017, which was a State of the Science meeting that many of the national experts in renal cell carcinoma attended. And the purpose of the meeting was really to revisit what our eligibility criteria and also how we're, declaring recurrence and stuff, and to see if we can make these trials a little bit more inclusive as well. So obviously, first, histology, we know for a long period of time has conferred both different behavior and recently molecular profiles. The World Health Organization, as you know, has many different histologic subtypes developed. And basically what this slide is demonstrating is that there's different molecular different behavior and different molecular profiles. But progression risk can also be determined by genomic factors, as we know from the TCGA and also from a number of other large wide genome using DNA and RNA analysis, where we've seen tremendous heterogeneity that can be now correlated, at least in the metastatic setting, to clinical outcome. Some of this work is now being applied to the ASSURE adjuvant trial, and that may give us more insight into recurrence risk. So one of the things that was hotly discussed was whether we should just include clear cell patients or non-clear cell patients in this discussion. And I just note that, in addition to the VHL inactivation, you need other mechanisms to lead to tumor progression, we're getting better and better at identifying these different pathways, which is leading to potentially more druggable targets. And in the non-clear cell pathways, there are also, the tumors are starting to differentiate. This is a slide of the EMOTION trial, which was expanded on just very recently. And what this slide shows is both some work done with DNA aberrations, but also RNA transcriptomes. And just yesterday, and I'm sure you'll hear more about this later in this conference, but a paper came out in Cancer Cell from the same investigators, which clearly outlines 7 different clusters of DNA aberrations and RNA transcriptomes, which can be related to different behavior in response to a VEGF inhibitor versus a combination of a VEGF inhibitor with an immune checkpoint inhibitor. And in papillary renal cell carcinoma, this is a demonstration that you can also prospectively test patients with known driver mutations and test drug efficacy. And so this trial clearly showed in patients with MET-driven aberrations that you can differentiate activity in savolitinib versus sunitinib. In chromophobe cancer, we're also making progress. This is science that was presented or published actually 5 years ago already by Kim Rathmel and colleagues, which clearly identifies different mechanisms in the chromophobe cancer population. And although the targets are a little bit trickier to refine and develop drugs, I think we're moving forward in this as well. So our conclusions in our meeting were that in addition to histology and stage, we feel optimistic that molecular characteristics will be useful and maybe on the cusp of being integrated into both prospectively in metastatic trials and eventually into adjuvant trials, and that we should include non-clear cell renal cell, especially if the driver mechanism is relevant to the drug being tested. So what other patient characteristics are important? Certainly body mass index, we know as far as drug tolerability and also metabolism and performance status. Pharmacokinetics have been demonstrated, at least in the adjuvant PROTECT trial, as being somewhat important. And this slide, what I want you to look at the top of the slide is the group at the top of the slide are all the adjuvant trials and the CTC grade reporting and the incidence of grade 3 or higher. And then at the bottom are some of the frontline trials, which albeit were reported earlier, but you can see that the recording of side effects of grading was substantially lower in the metastatic population than in the adjuvant. And so tolerability is certainly important. And I don't have much other time left, but I just want to note what Steve Campbell already noted, which is renal function is associated with life expectancy, but largely our patient population has impaired renal function. And so there are many things that we can do to be inclusive of these patient populations, including the newer second generation gadolinium, imaging. And if the drug isn't metabolized by the kidney, these are certainly patients who should be included. We will focus more, I believe, in the panel discussion, but other things that were discussed were surgical standardization, including, might we include patients with positive surgical margins if they're microscopic, for example, renal vein, just so many patients get left out. This is indeed a higher risk population, but I think by looking carefully at the statistics, we can be more inclusive. And putting it all together, I think the PROSPER trial is an example of, working with patients and designing trials that the patients are excited about and that they want to enroll in. So in conclusion, I think we need more molecular characterization for risk stratification. The trial eligibility and interpretation should account for other differences in recurrence between the higher and lower risk disease. We should be inclusive but not sloppy. So, the data needs to be collected. The stats need to be taking these into account. The drugs need to be tolerable or ways to keep patients compliant. And certainly urologists have now embraced both neoadjuvant and adjuvant trials. And so I think both are valuable. So thank you very much.
Thank you, Dr. Haas. It's my pleasure to introduce next Dr. Rajan T. Gupta from Duke University Medical Center. Dr. Gupta is chief of the Division of Abdominal Imaging at Duke and holds the rank of Associate Professor of Radiology with tenure. He's also been awarded a dual appointment at the Duke University Department of Surgery based off his work with colleagues in the Department of Urology, and holds a secondary titles of Associate Professor of Surgery and faculty at the Duke Cancer Institute. I apologize for my camera right now. Dr. Gupta has also authored and co-authored approximately 100 peer-reviewed publications on topics ranging from imaging with hepatobiliary specific MR contrast agents to multi-parametric prostate MRI. He's been given more than 100 invited lectures across the United States and internationally, and has been a co-investigator in 2 NIH R01 grants with Duke Biomedical Engineering. Dr. Gupta, take it away.
Thank you so much. It's a real pleasure to be here. I want to thank the Kidney Cancer Foundation for the gracious invitation, and excited to be part of this great group. So what I'm going to be talking about here is imaging endpoints, specifically RECIST and the immune-related RECIST categories. So as we all know, RECIST is a fundamental basis of how we determine response to chemotherapeutic agents, and it's the response evaluation criteria in solid tumors. It originally started in 2000 with RECIST 1.0 with the concept of 10 lesions, and then got iterated to RECIST 1.1, which is where we are currently at, which started in 2008 with 5 lesions. And those 5 lesions are basically 5 lesions in a patient with no more than 2 lesions in any individual organ. When we talk about RECIST and we talk about response, the first thing that we really have to break down is the concept of measurable versus non-measurable disease. So measurable disease is defined very specifically in a unidimensional format as lesions that are greater than 10 millimeters in size on CT. Specifically though, lymph nodes have to be greater than 15 millimeters in the short axis diameter, and non-measurable disease are all those that do not meet criteria by size or any other lesions. Special circumstances of RECIST 1.1 include bone lesions, and bone lesions, if they are bone-only lesions, cannot be considered measurable disease. Caveat being that if you have a soft tissue component of a bone lesion that is outside of the cortex of the bone, you can consider that in fact something measurable. When it comes down to determining progression and disease progression, when it comes to bony metastatic disease, you can look at bone scans, but it's important to take a look at more than a few exams in a row, at least 2 exams, 3 exams in a row, to determine whether or not flare phenomenon may be causing the changes on the bone scan as opposed to treatment effects. When we talk about RECIST 1.1, we talk about response categories. And so the complete response category for measurable disease is disappearance of all target lesions. The partial response category indicates that there's a greater than 30% decrease in the diameter of the target lesions. Progressive disease indicates that we are going in the opposite direction and that there's a greater than 20% increase in the diameter of the target lesions, or that we develop new lesions, the concept of new and increasing lesion size. Stable disease indicates that we simply have neither sufficient increase or decrease to fall into the PR or PD categories. When it comes to non-measurable disease, definitionally, we can only have 3 categories. We can have a complete response category where we have disappearance of null non-target lesions. We can have a non-CR, non-PD category where we have persistence of at least one of the non-target lesions. Or we can have a progressive disease category where we have unequivocal progression of the existing lesions. Or that we have new lesions again. So we have RECIST 1.1. What is the rationale for the concept of an immune-related RECIST? Well, the first reason for the concept of discussing an immune-related RECIST is the idea that RECIST 1.1 has potential shortcomings in the settings of immunotherapy. Specifically, the concept here is that given the reliance on the unidimensional size, it is possible that in certain situations, we might declare progressive disease too early prior to the full treatment effect that can occur. So the reason for that is pseudoprogression. And pseudoprogression is really characterized as an atypical response pattern with immunotherapy. That would include delayed tumor size reduction, potentially a mixed response, or an initial tumor burden increase secondary to increase in lesion size or newly detectable tumor lesions with a subsequent decrease in tumor burden. The other possibility instead of pseudoprogression is the concept of hyperprogression, and that is where you have a greater than 2-fold increase in tumor growth kinetic as compared to the pre-therapeutic state. So you can imagine the potential impact of a pseudoprogression situation or a hyperprogression situation if we use RECIST 1.1. It's important to realize that there are variable rates of pseudoprogression across different tumor types. So some literature has shown us that melanoma can be on the high side, and that other literature has shown us that bladder and kidney cancer can be on the lower side of pseudoprogression. But as we all know, kidney cancer has an ability to really go anywhere that it wants and can be a challenging tumor from that perspective. This issue of irRECIST, though, is critical because if we use RECIST 1.1 and pseudoprogression potentially occurs, it could lead to patients being erroneously removed from treatment and potentially unjustified patient exclusion from clinical trials. So when we talk about this irRECIST versus RECIST 1.1, it's important to know some of the similarities. The similarities are basically that for lesion inclusion and measurement. Again, specifically that there is no evidence, that there is no bidimensional measurements that are suggested inside of this. The key difference, though, is that in RECIST 1.1, when you have new lesions, it simply goes into a different category. When you have immune-related RECIST, the concept of newly measurable tumor lesions are actually added to the sum of the target lesions. And only a significant increase of the immune-related response criteria of greater than or equal to 25% or irRECIST criteria of greater than 20% size results in determination of tumor progression, or specifically IPD, immune-related progressive disease. This is an example of just how it's utilized. We have the initial tumor burden here, and we break down our lesions, again, 5 lesions total, into measurable and non-measurable lesions. We'll break those into the target lesions and non-target lesions, which we utilize. The interesting thing here is RECIST 1.1 can be used throughout this pathway. The only time irRECIST really comes into play is in the concept of new lesions and how they are differentially dealt with. So let's talk specifically about that. The nuances of irRECIST include the fact that there's a category called unconfirmed progressive disease, or IUPD. That basically means that new tumor lesions within irRECIST will also be classified as tumor progression, but it's important to realize that these can be reassessed in dedicated earlier follow-up after 4 to 8 weeks as compared to the traditional 6 to 12-week follow-up. And this is clearly recommended so that we can continue the idea of immunotherapy at the first stage of this unconfirmed progressive disease. It's also important to realize that overall response categories take into account the concept of both target lesions as well as non-target lesions when making an overall assessment of patient response. When we talk about irRECIST, the response categories are the following. You have a complete response, or an ICR. That means that complete disappearance of all target and non-target lesions, and specifically that all lymph nodes must be non-pathologic in size and less than 10 millimeters in short axis diameter. When we have a partial response, that means that the tumor load of the target lesion specifically is reduced by less than or equal to 30% compared to the baseline, or with complete remission of the target lesions when one or more non-target lesions can still be distinguished, differentiated from complete response, whereby obviously these are non-target lesions cannot be distinguished. Finally, stable disease again comes into play when you talk about ICR or IPR are not met and there's no tumor progression present. Some additional nuances are basically the following. As I mentioned, RECIST 1.1 can be used throughout the pathway of tumor response, but and that's because of the fact that most patients are not going to have pseudoprogression. It is still an atypical phenomenon. irRECIST is only really relevant once progression is suspected, and specifically in the categorization and determination of how new lesions should be considered. It's important to realize that irRECIST is not fully vetted, and it's not a simple system. There's actually, in fact, the quick training guide includes 90 training slides. So let me just show you an example of this. This is a patient with clear cell renal cell carcinoma. I've got these CTs on liver windows so that we have better delineation of these hypervascular liver metastatic lesions. And so we can see at the baseline there are a few scattered lesions seen throughout that are target lesions. As we go to time point 2, we can see that there has been an increase in size and number of these lesions. So this would be considered progressive disease by RECIST 1.1, based on its change from the baseline to time point 2. However, the question comes up really is this potentially unconfirmed progressive disease based on the fact that this patient is on an immunotherapy? So the only way for us to determine that is by taking a look at baseline time point 2 and then a quicker turnaround on time point 3. And so we take a look there at time point 2 now compared to time point 3. Again, liver windows to increase the conspicuity of the lesions on arterial phase imaging. And you can see here that there is a decrease in size and number of those lesions, both compared to time point 2 as well as compared to baseline. So in fact, this was pseudoprogression by irRECIST and actually complete response by RECIST. One quick plug is to realize the importance of the phase of imaging for determining complete response. So in this particular case, we have the arterial phase imaging, which showed us the hypervascular lesions. It's important to realize that these lesions haven't actually disappeared completely, in the fact that on portal venous phase imaging, you can still see some areas of low attenuation throughout the liver, and just sort of a plug for dual phase imaging in the setting of clear cell renal cell carcinoma. To summarize, RECIST 1.1 remains a standard for evaluating treatment response for most tumor types and therapies, but it is important to realize that immunotherapy does pose some unique challenges. I think that irRECIST is an interesting start and begins to give some insight into pseudoprogression, specifically to ensure that we keep patients on trial that need to be on trial and prevent us from removing them from trial based on the concept of pseudo or hyperprogression. Thank you very much for your attention.
Thank you, Dr. Gupta. We're going to see questions for Dr. Gupta and Dr. Haas's talk for the perioperative trial design roundtable, which we're going to move to now. And there we're going, Dr. Alof is going to join us. And Dr. Alof is a professor of urology and oncology at the Johns Hopkins University School of Medicine. He also serves as the executive vice chairman of the Department of Urology and the MEA endowed director of minimally invasive and robotic surgery. And so we have just a couple of questions from the audience so far. The first one is for Dr. Haas. What is the value of having a separate arm for non-clear cell renal cell carcinoma patients in clear cell renal cell trials when the biologies are totally different? And when will we have non-clear cell renal cell carcinoma specific trials?
So those are very good questions, and I don't necessarily think that they need to be a separate cohort if they're randomized. I think that there is some overlap in mechanisms, where we know that some drugs work in both, in both settings, and in that situation, I think that where it makes sense to include these, we should include them. I think that you're asking a very good question, for industry and the cooperative groups about if we have a home run in metastatic disease for a particular non-clear cell group in metastatic disease, should we be looking at testing this in groups of patients with a particular molecular phenotype or histology in the non-clear cell setting? And I hear you, and I think that we some of it comes down to how big the sample size is going to be too. Do we have enough patients that we can go ahead and do something like that? And we probably do in papillary renal cell carcinoma. I'm not sure that we have that in chromophobe or some of the rarer types.
The next question from the audience, probably for Dr. Gupta. RCC is known to be heterogeneous and have mixed responses to treatment. Shouldn't there be a way to incorporate responses in lesions that respond to treatment but weren't chosen as one of the 5 target lesions?
Very interesting question. So as I mentioned, RCC is definitely known to be heterogeneous. And I think one of the interesting parts about taking a look at these things from an imaging standpoint from RECIST is just that there are tons of nuances when it comes to RCC. Anecdotally, what we've seen is there are certain types of RCC that when we take a look at the target lesions, as a radiologist who's looking at these studies, you can only do so much when it comes to target lesions because to some extent there is some art and science to choosing the target lesions. As a radiologist who basically focuses on this for our group, I have to almost see into the future to determine what lesions are going to be the ones that are going to do best predict the response of the overall patient. And what I've found is that renal cell has a very heterogeneous structure and sometimes comes back in different ways, and that while the target lesions have been there. So what we're really focusing on is the idea of how do you deal with those nuances. And I think that that's in part why irRECIST was brought in, was to say that now you are bringing those new lesions in as potentially back into a re-baseline, if you will, to determine response, as opposed to simply looking at it at the 5 that were chosen at the beginning.
Thank you.
Dr. Loth, based on prior and ongoing trials, what do you think the appropriate role of nephrectomy is in locally advanced renal cell carcinoma? And has your practice changed over the past few years?
Yeah, thank you, Dr. Locally advanced renal cell carcinoma, the role of surgery, I believe that surgery is a mainstay in that a very, again, heterogeneous group of patients. It's also a very interesting group of patients because imaging plays a good role in defining what locally advanced the disease is. There's conventional imaging, but there potentially are emerging molecular imaging agents such as CA9 and PSMA-based therapies to look for metastatic sites that may change the calculus for local surgical therapy versus systemic therapy. There's also opportunities for perioperative therapies like Dr. Campbell talked about, the VEGF agents. and the PROSPER RCC trial is looking at immunotherapy agents for this very patient populations. There's opportunities for technical refinement, opportunities to look at sarcomatoid and rhabdoid histologies. But I think in summary, I'd say this is a heterogeneous group of patients because you can have locally advanced disease by virtue of venous wall invasion, venous thrombus involvement, adrenal invasion, synchronous, ipsilateral, adrenal involvement but not invasion, capsular and fat invasion, T4 disease, adjacent organ involvement, and then finally, of course, lymph node involvement. And each of these, from a clinical standpoint, represent a unique patient population. But I would say that in all of those settings, we have data, not high-level data, but either prospective early phase data or retrospective data showing that in all of these settings, surgery can afford a significant percentage of these patients to have a recurrence-free survival interval, and for some, in some cases, say venous thrombus, 40 to 65% of these patients can have disease-free survival, in 5 years with surgery alone. So I would say that we still think of surgery as a mainstay for these patients, but they're ideal for clinical trials like the PROSPER RCC trial, where immunotherapy is being used neoadjuvantly and then, of course, in the adjuvant setting as well.
Thank you, Dr. Olaf. We have a question for Dr. Haas. You presented multiple therapies for multimodality treatment in the neoadjuvant and adjuvant setting. Do you think there is going to be a winner that we're going to see come out in the future, especially for, the community oncologists where they might not have the opportunity to be put on these really important trials? Is there one that's going to take them all, like not a la Lord of the Rings? But if you have any comments on that, Dr. Haas, that would be great.
So, I think that based on the way the statistics were designed and based on the fact that 2 of the trials finished accrual a while ago, I think we're going to have the answer soon. I'm happy to say that the PROSPER trial is more than 75% accrued. So we'll have 3 trials that are sort of incubating. It may take a little longer to look at the combination immune checkpoint inhibitor question, but hopefully we'll get some insight about the role of immune checkpoint inhibitor, at least as a monotherapy, soon.
Thank you. I think we'll go back to some questions from our audience. So from Laura Wood from Cleveland Clinic Cancer Center, she says, RCC is known to be heterogeneous and to have a mixed response to treatment. Shouldn't there be a way to incorporate responses and lesions that respond to treatment, but weren't chosen as one of the 5 target lesions? And I'll leave it to anyone who wants to respond on the panel.
I'll just weigh in and say that there has been a real plea to develop trials that are a real life scenario, because we're all dealing with these questions. And I think the devil is just in the detail of how we do that. But, I think that, one design might be to allow patients who progress at a particular time to get therapy. There are some trials under development that are being proposed. As far as the cooperative group goes, the NRC has recently proposed a frontline trial of nivolumab, I think with cryoablation. And we in the cooperative group at ECOG have proposed a trial where patients who are progressing on an immune checkpoint inhibitor could undergo some kind of either cryoablation or embolization procedure to the metastases as one of the arms to see if we can continue to see responses. But I think that there are other ways to do that. For example, adding in drugs in a patient population where they are doing well in most cases on a particular therapy. And if there is a non-interacting, or a tolerable combination that could be active, I think that's another important question.
One other question, which is an interesting one. Any insight from the panel on the FDA's perspective on irRECIST or irRECIST?
Very interesting question. One of the things that's really challenging here is that the concept that like RECIST 1.1 has been around for a while and is probably due for some kind of a refresh. But at the same time, there's been so many different like versions of RECIST 1.1 that have come out in regards to certain other tumor types. So I don't know the standpoint currently of the FDA in regards to it. I went through the group who originally published RECIST 1.1 and then actually are the ones who put out that training guide for irRECIST, which is about 90 slides. But I think what it really comes down to is once we figure out what the FDA thinks about it, then the question is how quickly or how appropriately can it be integrated into other trials? Because I think right now the majority of trials are still using 1.1 as their primary, and endpoint's not really, but the primary system for measuring. And the question is, how many of these trials need to reincorporate the concept of an irRECIST or an irRECIST into the assessment categories, and how easy would that be to do, and how retrospectively you have to kind of go back and do that. So I don't personally have any insight into the FDA's thought process on this. I'd be curious to find out if anybody else on the panel does.
Any other comments from the panel members? Okay, then we'll go on to the next question from Dr. Zhang at Duke Medical Center. And she says, we have just added irRECIST criteria to the pedigree trial as part of the Alliance Cooperative Group initiative to use irRECIST criteria across all immunotherapy trials. What challenges does the panel think will be present to implement irRECIST criteria during an ongoing trial? Dr. Haas, do you want to start with that?
So the question is for an ongoing trial. I think that, part of it is just getting people up to speed because they're less familiar with it. Although, we used to always do bidimensional measuring before the regular RECIST got implemented. So I don't think that it would be hard to do with some education. I don't know if I'm answering the question that's at heart.
I would totally agree. I'd like to agree with that thing that I think that one of the unique factors about irRECIST is that it doesn't get implemented at the baseline. It only gets implemented at this concept of the progressive stage or the potentially pseudo-progressive stage. So I agree with you that the challenge is going to be familiarizing people enough with something that they've heard about, but maybe have not utilized in these trials. And then determining, do you have to go back to the points at which progression was thought to have occurred and then potentially reassess? I think it's a challenging thing to determine that, and obviously would be great if we sort of looked at it more prospectively right from the get-go, that when progression is there, we almost have like two arms of it that state what happened with RECIST 1.1 versus what happened with irRECIST, and then see how those pathways either converge or potentially diverge.
Thank you. Another question from the audience. Is there a role in biopsies of the non-responsive lesions when other lesions are clearly responding to an IO agent? Dr. Haas? Or Dr.
Yeah, can you repeat the question?
Is there a role in biopsies of the non-responsive lesions when other lesions are clearly responding to an IO agent?
So we probably should both answer that. I think it could be important as we're familiarizing ourselves. If we're now starting to put biomarker data and stuff into analyzing, it's a little bit challenging in renal cell because it's not something where we've had mutational burden and mutations and stuff to sort of drive therapy the way it is in, for example, non-small cell lung cancer. But I think that the only way to sort of move the field forward is, especially in the clinical trial setting, if that happens, to encourage people to collect biopsies so that it can be compared.
Dr. Love, if you wanted to weigh in, please feel free. Otherwise, I'm happy to give a couple.
No, I mean, I was just going to talk about, if anything, about your biopsies and diagnostic yield of smaller RCC sites, the hypervascular also nature of RCC. Just make biopsies sometimes, especially if non-index lesions, to be technically difficult from a targeting standpoint, but also from a pathologic analysis standpoint. But I agree with Dr. Haas and her assessment of, we need to learn about all of this, and I think the jury's still out.
And I'd add on to the fact that I completely agree with everybody that there are these unique RCCs that basically feel like on the target lesions that they respond really well, and then all of a sudden you see these new foci that are developing. And I do think that there's some insight that we can gain from finding out, are these new RCCs, are these unusual mutations of the RCC, or what exactly is going on, but that they need to be of a sufficient size where we can really do some biomarker analysis and some more advanced pathologic analysis than simply determining RCC or not. Because most of these things are going to be that. They're going to be RCC. The question is it the same or different than what we've already seen?
The other setting you could think about it is if you had a patient that had, for example, a small proportion of sarcomatoid features and they were responding well, and then their disease just explodes. If you biopsy it and you have a big enough biopsy that you could see sarcomatoid features, that might, if you weren't using an immune checkpoint inhibitor, that might steer you in the direction of using an immune checkpoint inhibitor.
That's a great point.
Thank you. Dr. Aloff, in general, where do you see trials going in the near future for advanced clear cell carcinoma? What are kind of some of the next big questions that you think we need to answer?
Yeah, thank you. My big interest is in these locally advanced setting, and I think as Dr. Haas and others have sort of talked about, I think we need to be a little bit more innovative in terms of how we classify some of these tumors. And I do see a big role for some of these advanced imaging techniques, particularly carbonic anhydrase 9 imaging, maybe even PSMA PET scanning, which we all know about from prostate cancer. But we do see signals, in clear cell in particular. It's heavily sort of expressed in the neovasculature of clear cell renal cell carcinoma, and incorporating those types of imaging agents to better stratify the earlier stage patients to better select a higher risk population. But clearly, I think combination therapies are going to be sort of the mainstay of trials, moving forward. But we have to be cognizant of toxicity of those combinations in patients with potentially cured disease at nephrectomy. And that's sort of where I see my neck of the woods kind of going. And obviously, I'm enthusiastic about neoadjuvant approaches and looking forward to the readout from Prosper RCC.
Thank you, Dr. Aloff. One more question from the audience. For Dr. Gupta, it seems. Can you comment on the initiatives to adapt RECIST for VEGF TKI, where tumors responding resulting in liquefaction and paradoxical growth, which a physician may not appreciate with tumor measurements alone without actually looking at the images?
Sure. I think that the concept of the numbers not showing the importance of like what's actually happening and the need to look at pictures or need to look at the specific images or have context with the radiologists who are looking at those things, I can't overstate. I mean, we do that here, and I know many people do it in other places, but a lot of the real benefits that I feel like we can give our patients come from the discussions that we have between the radiologists who are looking at these things, both from a clinical standpoint as well as from a RECIST standpoint, as well as with the oncologists or the clinicians who are treating them. And so I do think there's some nuances that sort of come to that thing. There have been other tumor types where we really sort of looked at the viable portions of tumor as opposed to the overall size. So especially with tumors that have liquefaction that may appear larger, but actually their viable components are smaller. We've done that things in situations like HCC. But I think that it's still an area of growth. I think that clearly unidimensional measurements as a whole are not going to be enough to make decisions on therapies when we have all these new therapies that are out there. And I think some iterations to RECIST 1.1 are going to be needed in order to do that for moving forward.
Thank you. Just checking if there are any other questions from the audience here. Doesn't look like anything right now. Are there any, we're getting close to the end of the session, are there any kind of final comments that one of our panelists would like to make before we wrap up the session? This has been really great. Okay. Well, if there are no final questions, no final, then we'll wrap up the session. Thanks everyone for joining us. Really appreciate it.
For me, the faculty will be in the networking lounge and be available for more discussion. And next is the non-CME satellite symposium. We encourage everybody to visit our exhibitors in the exhibit hall during the short break. Thank you again for attending. We appreciate it.
Thank you.
Thank you.